All right, welcome back to another episode of PT Meal Podcast, a buffet of play, therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation of physical therapy, profession, and practice. I'm Johan de la Paz, your host. Great to have you back on this podcast. So, last September, we celebrated World PT Day, and the theme or campaign for that celebration for this year was long COVID and rehabilitation. And that's what we're going to talk about today. So to help us with the topic, she is one of the founding members of Long COVID Physio, an international support group of physiotherapists who themselves had COVID and are trying to increase awareness of the effects of long COVID. So let me welcome Daria Oller. Daria, thank you for being in the podcast.
Oh, thank you for having me. I'm
All
excited to be
right.
here.
Yeah. So, yeah, when I was researching for the celebration of World PT Day, just to, increase awareness again with my fellow physical therapists in the Philippines, I came across your website, Long COVID Physio, and that's why I was so excited to invite anyone in your organization to this podcast to give increase awareness to what long COVID is, because we all know, so far we're familiar with COVID and its effects, but we're kind of right now discovering what long COVID is. And not many people have encountered or handled patients with COVID, so it's somewhat new. Even like for me, I haven't, I don't treat patients with COVID, so that's why when I heard about long COVID, also, so there's some persistent symptoms after COVID. So that's what I'm excited to talk about, and also coming from the experience of someone who had COVID and physical therapy perspective. So, but before we really dive into that, could you give us a little background on who you are, what your current practice is, and why physical therapy? Why did you become a physical therapist?
Sure. So I started my undergrad degree is in athletic training from James Madison University. So working predominantly with athletes. I worked a lot with college level athletes and high school level athletes. And while I was finishing my AT program, that's when PT was really pushing to move to a doctor. And I was just kind of went, what about PT? So I looked into it and it just seemed really interesting. And I always like to be like fully honest that I really only knew like ortho outpatient. I wasn't familiar with all of the other settings. But it seemed really interesting to me. So I went on to PT school at Seton Hall and I graduated 2010. And after that, I went to Penn State. I was in a PhD program for 4 years doing research on youth sport injury and illness epidemiology at Penn State Sport Camps. So just studying all the injuries and illnesses that were happening to the campers. And at the same time, I'm also a dancer. So I was teaching dance at a nonprofit studio that's down the street from Penn State. So then I moved back to New Jersey and started working in ortho outpatient at a little clinic. And then January 2020, I switched jobs to where I am now, which is Proactivity, which is in Lebanon, New Jersey. So my time is split. Part of my time, I'm in an outpatient clinic, predominantly orthopedics, lots of athletes, but some other chronic conditions also. And then in the mornings, we have employer clients, which means we go on site to people's workplaces and we're working with construction type workers. And we do a lot of prevention and health promotion. So we're there to help people, when they get injured, whether it's work related or not, but also trying to get upstream and get ahead of things and talk about the importance of eating well and exercising and sleeping well and connecting with other people. So it's a lot of fun. It's
Right.
really interesting to have such two different aspects to what I do.
Uh-huh.
Yeah. So I didn't know, like I said, I didn't know any of that existed in physical therapy.
So how different is it from like your work clients side and to your athlete side?
Yeah. So okay. So like comparing like the employer clients to
Uh-huh, uh-huh,
athletes. Oh
uh-huh.
yeah, it's interesting because on one end we think of like a traditional athlete as somebody who plays a sport, usually
Mm-hmm.
on a team, maybe not always on a team, and they have a structured training program and the goals, whatever they want to achieve in athletics. But when you look at those construction workers that we're with, I mean, it's so incredibly athletic, and to see the things that they do and as I'm learning more and more about this,
Uh-huh.
the positions they have to get into and the extreme conditions they're working in, like with weather and there's emergencies, when we have bad weather. So while they might not be formally like training for their job, it
Mm-hmm.
takes so much so much strength and fitness and mobility. And
Mm-hmm.
so our approach with them is trying to, we're teaching like they are still athletes. Maybe they're not on a sports team, but they are still athletes at their job. And it's a really big push then to get upstream for things because their jobs are so demanding and they're at them sometimes for decades, that we want to make sure they're healthy, not only for the current time that they can work, but afterwards that they're able to, retire and enjoy their lives.
Right, like construction. When you said construction works, I'm thinking about like people who really carry a lot of things, heavy weights,
Yeah.
and
Yep.
oh, okay,
Yeah, that's
yeah,
part of it. It is amazing to learn about all the things that they do. And
uh-huh,
even with that, like not all, but in the clinic, some of the athletes I work with, they're young kids in high
mm-hmm.
school and college, but we also have we have a running club. So I work with the runners who are usually a little older or like middle age.
Mm-hmm.
But with our employer clients too, they're ranging from their like early mid 20s up to there's people in their 70s and 80s who are still working. Yeah. So
Wow,
I'm seeing a really, really broad age range too. And then
mm-hmm.
predominantly men, but there's women who work there also.
Mm-hmm. Wow, very very different areas and population and demands in their physical activities. Right. So let's get now into our topic, which is long COVID. But before everything else, can you describe to us what long COVID is? Is there already a census on what the definition is? Because when I was researching it, there was a lot of even names for it. There was like persistent post COVID. There was long haul COVID. So is there already a definite definition already?
Sort of. I feel like this is just like, I think it's so fascinating to be in the middle of as science is happening and we're
Mm-hmm.
learning things.
Mm-hmm.
So currently, and this will even vary depending sort of on where you're looking,
Mm-hmm.
but it's in general, it's that symptoms are persisting beyond 4 weeks after your acute infection. And the symptoms range, it can be multisystemic. It's covering, it literally can cover all body systems. So nobody's presenting the same. It's not like, say in my setting, like in orthopedics, somebody has an ankle sprain. It's kind of typical, usually
Mm-hmm.
how ankle sprains present. The symptoms really, really can range from some of the things we see in acute COVID, with like chest pain, shortness of breath, coughing, things like that.
Mm-hmm.
But the big ones, we're seeing people that have like crippling fatigue that we call post-exertional symptom exacerbation.
Mm-hmm.
We're seeing people with cognitive impairments, cognitive deficits. That's a really, really big one.
Mm-hmm.
Some autonomic dysfunction. So not that any of those are in like a set definition of COVID, but those are
Mm-hmm.
like common things that we're seeing.
Mm-hmm.
And what can be, what you already mentioned, what can be really difficult is the different names.
Mm-hmm.
So long COVID came from us. It came from the patients literally on social media who were
Mm-hmm.
coming together before the medical community and the research community were like recognizing us. And now we're seeing, there's different names coming from the World Health Organization, the CDC in the United States. Other researchers are adding things. Long haulers is one that has kind of gotten thrown into on social media. But
Mm-hmm.
an important thing I think for people to recognize is to be respectful and acknowledge what the patients are experiencing and what they're calling it. Because how
Mm-hmm.
many illnesses or conditions are there that like the patients were the ones who actually kind of started it,
Right.
that were the
Right.
ones bringing to the attention of everybody else. So from the
Mm-hmm.
patient perspective, we typically tend to call it long COVID. But
Mm-hmm.
we'd have to recognize there's so many other names for it right now.
Mm-hmm.
And something else that's really good to know with this is we're looking at like a definition is somebody might not have a positive test to confirm that they even initially had COVID. For those of us who got sick in the first wave in like
Mm-hmm.
spring 2020, there were no tests, or even people sick in winter 2020, there were no tests available. So people got sick and they may or may not have a known exposure.
Mm-hmm.
We're finding now there are people who are asymptomatic acutely. They had a positive test because maybe they had a known exposure or their job tests them, however often. And they were asymptomatic at the acute infection and then go on to long COVID later too.
Mm-hmm.
So it's not always that everybody has symptoms acutely and then they just carry on. They might have been fine and then the
Mm-hmm.
symptoms show up a couple weeks or months later.
Mm-hmm. Oh, that's interesting. I'll get to it
Yeah.
later because
I'm watching your face.
yeah, because when you were saying that, I was like, I'm so I've been like debating in my head that um there's something kind of wrong with me that I like feeling a lot of fatigue. There was a time that we went hiking and days after I experienced I was so tired, not normal with how I usually like do stuff. And I initially I thought I was like, am I depressed? Am I am I
Oh,
just
yeah.
am I just like sleep lack do I just like lack sleep?
Mhm.
And when you were telling me that, and then I was thinking about that, and I wasn't sure if I was exposed as well, if I had COVID back in 2020. So that's quite interesting. And I've had a lot of negative results, and I don't know.
Yeah,
So
and
that
it's
kind of explains
fascinating
it.
with it. Yeah, and us
Mhm.
in healthcare, I mean, everybody, it's probably to some degree has some sort of exposure and didn't
Uh-huh.
know. Like I'll say for me, I had a known exposure, not even working. I was dancing in New York City in
Hmm.
rehearsal. I could have had exposures at my old job in a clinic because we were
Hmm.
right outside New York City. Don't know. Yeah,
Hmm.
so that's what it's so interesting with it. There isn't like a set, definite way to confirm somebody acutely had COVID necessarily. Um, and then at the same time, there's no set diagnostics for long COVID. We know people are presenting certain ways sometimes,
Hmm.
but there isn't like a blood test to say you have long COVID. There isn't certain imaging that's going to say that you have long COVID too. So right
Hmm.
now it's sort of putting together that you may or may not have a confirmed acute infection,
Uh-huh.
but you are presenting with these symptoms that are lingering. There are certain patterns that we're seeing with it, and it's
Hmm.
saying, well, ruling out other things. Very important to rule out other
Hmm.
medical conditions. Saying, all right, this probably is long COVID.
So are the symptoms of long COVID for those who are symptomatic? Is it do they just feel that their symptoms are prolonged, or are there other unknown symptoms that they didn't feel before but
Yes.
suddenly came out? Oh, okay.
Yes, yes. So early on, and not that everybody's the same, but like the
Uh-huh.
big things seem to be like the respiratory issues people have acutely, some
Right.
cardiac things. There's fatigue that's definitely present.
Mm-hmm.
But later on, we're seeing things like hair loss. I've had
Mm.
that, and there's a lot of women who have, and you don't necessarily realize it. I thought it was stress, and then you're learning this is a symptom. People
Mm-hmm.
have developed some like allergic type things and changes in like sensitivities and foods and things like that. The autonomic dysfunction isn't always necessarily present early on. An exercise intolerance, where
Mm-hmm.
in the beginning, people might not be exercising because they're sick, they have a
Mm-hmm.
fever and things like that. And then
Mm-hmm.
after that kind of subsides, people are trying to get back and saying, whoa, what's going on? Like having that horrible fatigue, just not being
Mm-hmm.
able to do basic things like walking. Um, Not everybody has the cognitive dysfunction or the brain fog in the beginning. Sometimes that seems to be coming out later. Yeah,
Mm-hmm.
and it changes. That's one of the really tricky things. Even this morning on Twitter, there was an OT tweeting that she had she's had this for a while. She had heart palpitations last week and they're completely gone now.
Hmm.
And they're probably going to come back again because that's what happens with this.
Okay.
Everything, yeah, things can completely resolve. I always say it tricks you. Symptoms can seem to completely resolve, and then for possibly unknown reasons, they come back again. It's episodic, it's unpredictable. So that also makes it really tricky to sort of try to get a diagnosis and understand how to work with it.
So when did the medical community notice this? I mean, that they recognize that there is something after COVID.
It's been slow-ish. It
Uh
depends
huh.
on where you look. So in New York City at Mount Sinai in the Petrino lab, they were picking up on this kind of early in like
Uh
April,
huh.
May. They were just seeing that people were having these prolonged symptoms when everybody else is saying, oh, it's 2 weeks and you get better.
Uh huh.
So they're kind of early and they're on the forefront with some of this rehabilitation. And then from there, it's just been really slow kind of
Mm-hmm.
trickling. Articles are, I mean, months and months and months ago, things were getting published in big journals like The Lancet and Nature, but it's not like a set time. It's just been really, really slow kind of
Mm-hmm.
coming out. And I want to say, I could be off of this, but I want to say maybe by like late fall, winter last year, we're starting to like hear things. The
Mm-hmm.
media picking up on stories has been really helpful too,
Mm-hmm.
because unfortunately, I've been learning is easy for the medical community to dismiss things that they don't know and say it's in your
Right.
head, you're crazy, it's anxiety, it's depression, it's pandemic stress. But
Mm-hmm.
even as the media was saying, well, here's this story. And now here's
Mm-hmm.
another story. They don't know each other and the stories sound really similar. So that's
Mm-hmm.
been helpful to get us attention too. But yeah, even now still there is so many unfortunate like individuals and groups in the medical community that aren't recognizing long COVID or that are downplaying it.
Mm-hmm. And I met because it's, as you've said, it's kind of hard to really pinpoint if this is long COVID because it fluctuates, episodic,
Yes.
and you're not even sure if you had an exposure before it didn't have any positive result in a test.
Yeah, it's
So,
challenging.
so tell us more about your experience with COVID, and how did you start to recognize that you may have like those symptoms that point to long COVID?
Yeah, so in the beginning, so again, like I got sick right as the pandemic was picking up, right? Like literally the Monday of the week that everything was closing down here
Hmm.
in New York City and New Jersey. Acutely, I had a lot of body aches and like nerve pain, which is for me is a typical sign. I'm just getting sick in general. But kind of getting into the end of the week, like my chest was burning. I was getting shortness of breath. I
Hmm.
was trying to still trying to jog and walk and things. And it just wasn't feeling right. I knew
Hmm.
like this wasn't normal. And what got interesting was so Mondays when I really started to feel sick. That Sunday, I was like, oh, I think I'm over it. The body aches are gone and all of that. I'm like, all right. So I'm past the scary part. And then everything just got so much worse. So from there, it's kind of tricky because there were things at the time I didn't realize were symptoms. Like I knew
Hmm.
obviously like the breathing difficulties and chest pain were
Right.
symptoms because everyone was talking about it. But I was having a lot of cognitive impairments. My job was new and everything just moved virtual. So on
Hmm.
top of a new job, now I'm having to learn how to do all this computer work I typically wouldn't do. And I was struggling to learn, but I just thought I wasn't doing well on a computer. I'm used to being
Hmm.
face to face with people. And there were times I was getting really fatigued. Like we were out, me and my husband were walking our dogs, and I could have fallen asleep on the sidewalk right there. Yeah, that was a little scary. So stuff like that was happening. I go for a walk, and I was like recovering, like as though I just did a hard run.
Hmm.
But I just kept trying to push exercise because that's what we do, and that's what I've
Right.
always done.
Right.
And just not like kind of being in denial of how poorly I was responding to exercise.
Hmm.
I would go out and try to run, and I would have sworn it was like 90, 95 degrees, and it was like 70 something degrees. And I was
Hmm.
just struggling so badly. So, and this is at like June is when I started to hear like long hauler, but I didn't know anybody with it.
Hmm.
But people send me news articles. And then it's at the end of July where some PTs from the myalgic encephalomyelitis chronic fatigue syndrome had seen my tweets and reached out to me and really helped me. So they're DMing me all this amazing information. And I knew nothing about these post-viral illnesses. And it was just kind of like overwhelming and took me a little while to like grasp what was going on. And
Hmm.
even now I'm still realizing, oh, I still had no idea what was going on months ago.
Hmm.
So when they reached out, that's when I kind of started to learn about the post-exertional symptom exacerbation and maybe I shouldn't be pushing so much.
Uh-huh.
But after that, I watched a documentary called Unrest that's about chronic fatigue, and that was sort of that like, oh, like hitting home, like maybe this is really serious. So I thought I have this in a Facebook post. I thought I could take 2 weeks off from running and I would be fine. And
Hmm.
that was last August, and I'm still not back to running. Yeah, so like since then it's been like a whole roller coaster. There's points where I think I'm getting better
Hmm.
because my breathing feels better or my chest pain went away or my brain is less foggy. And then other symptoms get worse and then those symptoms come back and then I'm more fatigued and I'll crashes are what I call when I'm just that the post-exertion symptom exacerbation where I just cannot get up. I could go weeks without crashes and all of a sudden one happens again.
Hmm.
It's really unpredictable. Right now I think I have a handle on it, but it changes. Yeah. And this
Oh
is
my
pretty standard for
goodness.
people. While our symptoms do vary, like there's symptoms, like I never get a fever. Other people
Uh-huh.
have fevers. I've never had a fever. While those kind of symptoms will vary, the general theme of what I'm saying that like the symptoms kind of come up and down,
Hmm.
that we don't always see the patterns on why they're getting worse.
Uh-huh.
Sometimes I can tell you like, oh, I did too much this week. That's why I feel
Hmm.
like garbage right now. But other times I honestly don't know.
Hmm.
Yeah. So it's
Ah.
one of somebody in Long COVID Physio calls it the Corona coaster, which is
Ah.
pretty accurate.
The more
Yeah.
that you describe it, the more that I was thinking all of the symptoms that I was experiencing, the fatigue, the middle of the night, middle of the day, I would just probably crash while typing my notes and just walking
Oh,
up the
notes are hard.
yeah, like facing the computer and I'm like, what?
Yeah, that's actually like PT specific has been for me because I used to be able to just sit and notes all at once, no
Uh-huh.
problem.
Uh-huh.
And my caseload is much smaller than what it used to be just by nature of it's just a different job. And it is so hard for me to do notes, to try to do them between patients and or just to save them the night. Let me do them. It is so
Right. Something that
So
you
I've
do
had to learn how
normally,
to
right?
adapt. Yeah.
Yeah.
Yeah. Or another PT with long COVID, Ted Shane, was saying in an interview, he's an inpatient in the summers, and he used to see a patient, do a note, see a patient, do a note, and he can't anymore. He can't keep flipping his brain like that. So he has to stay on the patient care and then save the notes for the end of the night.
Oh,
Which hearing
wow.
that was really helpful to me, because I said, I'm dealing with
Uh-huh.
that exact same thing. And I hadn't heard another PT say that before.
Oh, wow. Well,
Yeah.
that is really helpful. Hearing something from other physical therapists, because
Yeah.
there was one day I was trying to think that it would there be a test that would tell you that you had COVID even after you had a vaccine, but I don't think there's a test like that, right? No, right?
Mm-mm. And even now, many of us have had negative antibody tests. So you
Mm-hmm.
can't even rely on that to like, oh, well, you had an infection at some point. And there's a theory why maybe we don't know why
Uh-huh.
some of us might have long COVID is maybe we didn't produce enough antibodies early on and we didn't, fully fight the virus. We're not sure. But like I
Mm-hmm.
had a negative antibody test 2 months after I got sick.
Uh-huh.
So we can't
Uh,
even rely on that.
right. So is there well, there's still some, talk about the definition and what long COVID is, but is there already a recommended treatment or management for people who are experiencing those symptoms?
It really varies. So
Varies.
part of it outside of like our PT scope
Mhm.
is there are medical things that have to be attended to. Like many people, unfortunately, I shouldn't say unfortunately, but will have normal blood work, normal imaging, like standard things. But there are
Mhm.
some people that were showing things that stuff has to be addressed.
Uh-huh.
But a typical treatment, not really. Some
Mhm.
of the bigger things, again, not for everybody, are economic dysfunction, which is where some diaphragmatic breathing is really helpful,
Mhm.
and monitoring people's heart rates to see how they're doing from like supine to sitting to standing, because we'll see some really funky big spikes in heart rate and changes in blood pressure, bigger than what you would expect to see with positional changes.
Mhm.
um, so it's trying to get the symptoms under control. And a
Mhm.
lot of that, if people are experiencing the fatigue, is teaching them how to stop, rest, and pace. So rather than pushing through and just trying to do your normal pre-long COVID life, is finding how do we save our energy.
Mhm.
Something that's really interesting that we've learned from other communities with chronic illnesses is the spoon theory. So
Uh,
that's where, say, you have spoons represent energy, and say you
okay.
have like 10 spoons for today, and this is your energy, is these 10 spoons. How are you going to use it? Are you going to go out on a run and there are all your 10 are gone and now you're stuck the rest of the day? Or how can you kind of spread it out? That I look at this as there are things that we definitely have to do. Like there's
Mhm.
certain like family responsibilities, house chores, whatever you have to do, going to work. So that requires spoons. There's some things that would be good, like maybe things that like make us feel good that are nice, but
Mhm.
we might not, they're not a priority. Like, okay. And then things that we shouldn't do because we know they're going to make us worse. So you really have to like consciously pick where you're using that energy or those spoons. So as PTs, we can help patients with that and
Uh-huh.
go through their days and find where there are opportunities to rest. How can we possibly like help you adapt to or modify your work or the things you have to do at home? So that's
Mhm.
really big if people are experiencing that fatigue, which is the most commonly reported symptom right now.
Mhm.
But the big thing too, that we've been really stressing is it's not the typical graded exercise that we would do with patients, whether I should say almost any other condition. Trying to push graded exercise and do a little bit more each time actually can make us worse. So you have to
Oh,
be, yes, and we know this from the chronic fatigue community because
so
graded
don't do that.
exercise has been pushed. You have to monitor the patient's response to exercise. There are some people that will do okay. They don't have the
Uh-huh.
post-exertional symptom exacerbation and monitor, but there are so many of us that it's worse. And when people have, unfortunately, whether it's like me that I just did on my own, or they're seeing the therapist and they're trying to push, well, you did this today, so we're going to do a little bit more tomorrow and the next day,
Mhm.
and they're crashing. They're coming
Mhm.
back and saying, I feel worse than I did before. That's when
Mhm.
we have to listen and say, maybe we shouldn't be doing this. And
Mhm.
I've seen one patient with it, an outpatient, and then a few of the construction workers I've talked to who have it. And that's where you kind of have to explain like your fitness level and your conditioning have to sort of sometimes take a back seat to getting the symptoms under control, because we all worry
Uh-huh.
about being deconditioned and losing our strength and being
Right.
sedentary. But if the symptoms are all over the place and not managed well, it doesn't matter. So that kind of takes the priority, is trying to manage your energy, use it where you need it, not use it on things that could potentially harm you. And
Uh-huh.
once they get under control, possibly being able to like start moving into some like light supine exercise.
I see. Okay. Because as physical therapists, like what you said, we try to push people or ourselves when we feel like this might be, movement is the key to everything, or
Yeah.
movement is medicine, things like
Mhm.
that. So we usually say, oh, okay, you just have to increase your physical activity. You just have to do better to tomorrow than the next day. Okay.
Not with this, yeah. And it's really teaching patients and helping them to feel that it's okay to be honest with us as therapists,
Uh-huh.
to say, no, what we did last time, I
Mm-hmm.
felt worse when I got home, and that they
Mm-hmm.
understand how to recognize the symptoms. Like I would miss, this is last fall. I can remember being in the clinic at the end of like long days and just kind of sitting like just feeling like winded. And I was also, in an N95 at that point. And I was like, oh, that's post exertional symptom exacerbation. But I didn't know that then. I was just thinking it was the big crashes. I was missing like smaller things were flaring up. So then I had to look back and say, how can I modify it? So I sit down whenever I
Mm-hmm.
can now to try to decrease how much energy I'm using.
And those things I brush off as being deconditioned. I mean,
Yes. Yep. That happens a lot. Yeah.
uh-huh,
And one thing we know though from the chronic fatigue community and the research on them is the response to exercise, it's not like DOMS or, I'm just like a little tired. It is
uh-huh,
not, sometimes not functioning in response
uh-huh.
to exercise. It's a really big difference from what you'll see. And that's the thing.
Right.
If you're seeing like, this isn't what I thought would happen, it's looking back and saying why. And sometimes you can, monitor their heart rate and their blood pressure in real time. If they have a wearable, like a
Uh-huh.
Garmin or a Fitbit, Apple Watch, whatever, look at that data too, because you
Uh-huh.
might see after your session, their heart rate was staying up. Maybe their sleep
Mm-hmm.
quality was really poor. They slept a lot, but they weren't recovering from the day before. Those are kind of some clues too that maybe the graded exercise isn't the right approach.
I
And we
did
have
think
to learn.
about that. Sorry, you were saying.
No, 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 go. No, no, go.
I did think about wearables because I remember when I was in a cardiac rehab in an internship, they had this strap on a polar device that really accurately measures their um,
Mhm.
heart rate. And so I was thinking of buying that because I didn't know what I was experiencing back then. I get tired easy, palpitations. I felt that too. Going up just two flights of stairs, got really like I was really exhausted after that. I was like, this is not usually what I experience, but
Yeah.
what is this? So I was thinking maybe I'm just too sedentary or too deconditioned, but I've been doing this for a long time, but why is it like this right now?
Right. And that's the stuff we see where it's something, say, like stairs are a good example, when
Uh-huh.
it's like a fairly abrupt or drastic change. I went from 1 week, I had no problems, to that first week when I was sick, and then continue after that, walking up a flight of stairs, especially if I was talking like on the phone,
Uh-huh.
completely wiped me out. And I would be so winded. I'm like, well,
Uh-huh.
I'm not deconditioned in 1 week. That's not going to
Uh-huh.
happen.
Right.
Yeah.
And
The
you're very
wearables are neat
active.
though. Yeah, yeah. Previous to super, super active, but the wearables have been great. So, like at my job at Productivity, we had they've before I was even there using Garmin's. We have a whole dashboard that's online called Scissors, where in addition to the data we see as clients on the app, there's even more. There's an amazing dashboard that's online. So they were using it to monitor their like strength and conditioning clients. But now
Mhm.
we have a whole program where we can monitor people. You can have a coach who's looking at your data and kind of pick up on stuff and say, hey, things look a little weird. And sometimes someone can be like, oh yeah, I just didn't wear it to sleep last night. Or oh yeah, I went out last night. I was having a good time. That's why stuff's weird. Or like picking up on maybe seeing somebody's getting sick before they know it.
Mhm.
Or seeing like in the cases of long COVID, like people aren't recovering well. You could see some weird trends in their heart rate. So it's really, really interesting. And I'm learning how
Mhm.
to use it more in also real time, because people
Mhm.
will see me like I look and I like go up the stairs, check my heart rate because they'll see a
Uh,
big spike.
uh-huh.
Yeah. And the Garmin doesn't always pick up those quick little changes.
Mhm.
So it's also teaching patients if they have a wearable, because so many people do, like how to use it and how to look at the data in their app, the trends, but how to also use it in real time to make decisions on like what you should be doing. Because if I see my heart rate's going up, if I'm walking up a flight of stairs, if I can, I will sit down when I get up that flight of stairs.
Mhm. Gotcha, gotcha. So
Yeah, the wearables are great.
with the stop, rest, and pace, is there? are we trying to manage the symptoms and not rehabilitate it for now? Mm-hmm.
Yeah, that's what's tricky. There are patients with long COVID who, again, will do well with like a typical kind of exercise,
Mm-hmm.
progression. But for
Mm-hmm.
the people that are getting those crashes, yes, getting the symptoms under control as best as we can
Mm-hmm.
is the most important thing. And I think a lot of us right now are finding, I'm in this boat. Am I actually recovering, like physiologically getting better from long COVID, or am I just
Right.
managing my symptoms better now?
Right.
I don't know. But
Uh-huh.
that's the biggest thing. Yeah, because it affects even the most basic ways to function. So we could help people be able to better manage their days, be able to
Mm-hmm.
go to work. One something that I find interesting right now, because we're hearing about like the worker shortage, and there's so
Mm-hmm.
many things that are being affected because employers can't find workers, and there's many reasons why. But one of them, I think, is there's so many people disabled with long COVID that they're
Mm-hmm.
not able to return to their jobs. Like I was just reading and hearing about with restaurants. I'm like, I would never be able to work in a restaurant, and that busy, fast pace, and
Mm-hmm.
things are changing so fast
Mm-hmm.
that could be a reason. So if we're able to help people better manage symptoms, they can better get back to work and make a living. That's so important.
Mm-hmm.
Yeah, and again, it's a big shift from I think how we're used to working with people. And
Right.
this is where OTs come in handy. This is where OTs are amazing to work with because this is stuff they've already been doing.
Energy conservation techniques.
Yeah,
Okay.
like adapting your environment.
Right.
On a more severe end of this with chronic fatigue, I just saw this recently. There's a guy on Twitter who was a professional dancer, beautiful dancer. He posted videos, and he's had chronic fatigue, and it's pretty severe. So somebody had built him basically like a bed. It's big in his kitchen, so he's able to lie down when he needs to prepare food.
Oh,
And
okay.
it's separate. This is not his bed. He's sleeping. He's not like sleeping in the kitchen, but because that's what things can take so much like energy that we would never think of. You're like, well, you still
Uh-huh.
need to cook. And I don't know his whole living situation, but so how do we do that? Adapt
Uh-huh.
the kitchen. There's a lot of things like that. Like I have a stool for when I shower sometimes to
Uh-huh.
sit because I saw that was making my heart rate go up really high. And that's like the first thing I'm typically doing in the morning. So
Mm-hmm.
again, pulling from the OTs with things like that, like how can we help people conserve energy? How can we help to adapt their environment? And we're in our society typically is not a fan of resting and pacing. We're like this very go, go, go. The more
Mm-hmm.
you do, the better.
Mm-hmm.
So it's trying to find ways. All right, well, here's where we're at, and like, how can we sort of help to adapt the environment so people
Mm.
can still go about their lives?
I think that would also there will also be a problem with that because not many occupations can be adapted or environment can be adapted. Um, not many environment are flexible enough to you know per- add any other stuff to adapt where your activity or adapt what your positions are. So
Right.
there's a lot of
Yeah.
challenges there.
Yeah, and that's something that's been interesting for me to learn from the UK because
Mm-hmm.
Long COVID Physio has a lot of PTs who are in the UK
Mm-hmm.
and other allied health professionals too. And not that anybody has like a perfect system right now, but
Mm-hmm.
because many of the people are working through the NHS
Uh-huh.
and they have their charter society of physiotherapists and occupational health, helping them doing like graded sort of return to work.
Mm.
So maybe I'm just making this up, but maybe they're doing 2 hours, 2 days a week, and that's where they're starting this like phased return, and then seeing how
Mm.
they respond, and maybe they could add a little bit and say, oh, maybe 3 hours a day is too much, and you have to go back. Some
Mhm.
people, PTs and OTs, are in settings where if maybe they're not feeling great, somebody can finish up their caseload for them, but that's
Mm.
obviously not the situation for all of us. So some
Mhm.
people are in those settings that can, to a degree,
Uh-huh.
kind of at least help on that end of it, but not everybody. That's just not, like when I was listening to people on the radio talking about restaurant workers, I'm like, there really isn't a way to modify. If you're in a busy restaurant, you got to
Right.
go. And yeah, that's been I think a very, very big
Mhm.
challenge. And one of my concerns with what's being missed with this is, so everybody I think knows early on from the beginning of the pandemic, we were hearing that um, minority groups are being most affected by COVID acutely, more severely ill, unfortunately dying more often. But
Mhm.
we're seeing with long COVID, it tends to be more people who are white. And my suspicion, because it is weird, is that people who say are maybe of a lower socioeconomic status, don't have a lot of resources, aren't able to stay home and rest and be
Uh,
counted as having long COVID because they have to keep working.
you have
So
to push through.
I think that's a yeah, I
Mhm.
think that's a big factor too, because that's a weird thing. I'm like, why is it two completely different groups from acute COVID to long COVID? And I think that's it. Not everyone
Mhm.
is in a situation right. They could say, yeah, I can't stop rest and pace. I have a family. I have a job that doesn't accommodate anything.
Mm-hmm. That's an interesting insight there. Um, so for uh people or physical therapists who would encounter patients that may or may not have COVID, how can they assess or you know
Mhm.
at least have an idea probably that this may be a long COVID? Is there already do we have an agreement on what are the things that we should look into in our evaluation and assessments with certain patients that we see?
There's not necessarily like a set thing, but there are like a
Mm-hmm,
couple important things.
mm-hmm,
Watch their heart rate,
mm-hmm.
monitor their heart rate, not only when they just come in and sitting and you get their vitals, but with
Right.
positional changes, with exertion. And exertion can be just receiving a history, just
Mm-hmm,
them, the cognitive demand of talking and
mm-hmm,
having to recall things and recall traumatic things. Keep that pulse ox on, watch their heart rate, see how
mm-hmm.
that's changing.
Oh, okay.
We have the Depaul Questionnaire, which is from chronic fatigue syndrome, which is looking at symptom severity. There's a lot of questions that there's two different ones that are available in it. So
Mm-hmm.
that's really helpful. But I will add on like the patient end of it. Every time I look at it, I just go, oh, that's so many words. So it might be, I like to point out, it might be us maybe reading it to them or only
Mhm,
doing part of it because you're grading, circling how severe your symptoms and all that. But that the cognitive demand could be a lot. That's a big thing. It's not only physical, there's cognitive and emotional
mhm,
demand. But that's an option. It's a way to sort of try to quantify um, the symptoms that they're experiencing. For World Physiotherapy, on the World PT-Day Toolkit, they have an activity tracker, which
mhm,
is really great. And there's ways for patients to fill in where their energy level was at. And so it's just like these little like kind of check boxes. And on the second page, you can actually like make notes of what was going on.
mhm,
But again, I like to point out with that filling out a full day every single day might be a lot. So maybe it's
uh,
kind of picking and choosing points. Because the other thing too, like the things we might typically do as PTs, like a 1 minute sit to stand test or like a 6 minute walk or a bird bounce or whatever, may be way too physically demanding. The
mhm,
person might be able to do it in time,
mhm.
but that might cause a crash later on.
I
So you
see.
kind of have to look at, yeah, it would be good to do these tests that, we do all
Mhm,
the time, but is it going to harm the patient and how much
mhm,
more am I gaining from it? If I
mhm,
know how many times they can sit or stand in a minute, does that matter right now? It
mhm,
might, you could say they do this many now, maybe they do this many a couple months later, but
mhm,
you have to weigh out if they're already describing that they're experiencing those crashes.
mhm,
Maybe we don't want to push those like those harder a 1 minute sit to stand physical assessment because that's
mhm.
happened to some of the PTs that have gone to the clinics. They've done these types of assessments and they're just completely drained afterwards.
Okay.
There isn't, and it's hard because for anybody dealing with insurance, they want outcome assessments, they want numbers on things,
Right,
and
right.
we might not safely be able to do those assessments that we always do.
Mhm,
So it's really recording like the signs and symptoms you're getting,
mhm,
monitor their oxygen. You have to look to if they're desaturating more than 3%. That's a good indicator to also probably pull back and maybe not push
mhm,
exercise, but monitor their response to activity. Even if you're looking at their heart rate, just at the start of your initial assessment and at the end, and see if there's any changes with that.
mhm. I
Yeah,
see.
and I've even this is just something I thought of, but with the one patient that I saw, it was a lot for her. I didn't even have her try to fill out the DePaul. It would have been way too much for her. But I said, just if you can just at the end of the day give your day a number where 0 would be awful, like literally couldn't get out of bed, couldn't do anything, or 10 would be this is great. I feel back to my old self. Just overall, give it a number, just
Mhm,
to give me an idea of like where you're at. And that's something that should, for the most part, maybe not
mhm.
everybody, be reasonable.
Right. Mhm. And you mentioned earlier as well to make sure to rule out other yeah,
Yes.
first.
This
Mhm,
I like to stress because there have been cases I've seen on social media where, because I'm in a few different long COVID groups, where somebody, they may or may not have COVID and long COVID,
mhm,
but they assume the symptoms were long COVID and then finding out it was cancer or, something else that yeah, is serious and
mhm,
possibly treatable too.
mhm,
So
mhm.
that's important to make sure that we're not just assuming,
Right.
even if
Mhm,
you're like, it's chest pain and they're desaturating, it's probably long COVID.
mhm,
Make sure they are seeing whatever the specialists are
mhm,
and not feeling like whatever our specialty or setting is that we don't need to have all the answers. We know
mhm,
whatever our area is,
mhm,
but being open to like refer them out, whether it's to physicians, to OTs, to speech is really important. Some people get voice hoarseness. That can be an acute symptom, Or that could be like, I get that because I don't have enough power coming from my diaphragm still, and we all like
Mm-hmm.
hyperventilate. So
Mm-hmm.
it's stuff like that, knowing who your other resources are in your area to help too, and to rule out other things.
Wow. You mentioned another symptom that I was like click again. Like, hoarseness, really?
Yes,
Oh my goodness.
that's a
Ah.
big one. Yeah. Early on, I mean, acutely that, that I'm like, all right, I see how that could happen. But yeah, a
Uh-huh.
lot of us have had that because so many people hyperventilate, and
Mm-hmm.
not even realize that's been going on for months. But tying in with that, we're obviously not using our muscles properly and straining to try to talk,
Right.
especially if you're straining with a patient trying to get through a mask.
Mm-hmm.
And we have all had older
Well,
patients that we
yeah.
really have to use our voices. And over a long day, that that takes a toll, and you could start to get some straining of your vocal cords. So that's where it's
Uh-huh.
great to work with a speech therapist or a vocal coach to help.
Mm-hmm. Yeah, I think I've seen a podcast from Long COVID Physio
Mhm.
talking to voice coaches. I forgot their
Yes.
names, but it was really
Yeah.
interesting. I saw that was,
Oh, love it.
oh really, breathing and voice was amazing. I forgot their names, but it was really interesting.
Yeah.
I would post the I can attach the link there so people can
Oh, that'd be
learn.
great. Yeah.
So talking
That
about
was a good
long
episode.
COVID, yeah, it was very. I was really
I'll add too.
surprised.
Yeah,
Mm-hmm.
I'll add with that too, because it's really interesting because the vocal community with vocal coaches and singers have also stepped in and
Mm-hmm.
saying they have this training. They might not be healthcare professionals, but they have learned how to breathe and use their voices. So they've
Mm-hmm.
been stepping in to help. So there are some neat programs you could find online. And yeah, I can't remember the top of my
Mm-hmm.
head, but Long COVID Physio, we have our own podcast. So they were
Right.
guests. And
Mm-hmm.
and this is great because they talk through learning as they go, and things
Mm-hmm.
that they thought they knew from working with people just typically,
Mm-hmm.
are different now with long COVID. And so if anybody comes across like locally or virtually, any vocal singing, whatever classes for long COVID, it'd be great. But again, you have to monitor for those crashes and fatigue, because something really simple like basic vocal exercises to warm up for singing
Mm-hmm.
might be too difficult, or they
Wow.
might be too straining on their vocal cords. But then this is also where there's PTs who obviously specialize in breathing and all of that. There are
Mm-hmm.
speech therapists who are great too. It's so just in the voice alone is so
Mm-hmm.
complex with long COVID.
Right. Right. So talking about long COVID physio, how did it start? You mentioned earlier before we started that you met with what's his name? Uh,
With Darren Brown.
Darren Brown. Yes, in Twitter.
Yeah.
So is that where all of it started, and how did it really went from a Twitter community to a organization that increases awareness of long COVID?
Yeah. Oh, this happened so fast too. So Darren and I had found each other on Twitter. I feel like I'd seen something. This is November. I feel like I'd seen something for him a little earlier
Mm-hmm.
because he was posting his lived experience, and I had been sharing just kind of not what I was going through.
Mm-hmm.
So we were talking, and like in tweets publicly, we're saying like we should have something. Like I was saying, I feel like we should be capturing this for our profession as we're
Mm-hmm.
going through it. And then he came up with the physio being in the UK.
Mm-hmm.
And from there, we started to find a couple other people. So we quickly started a little DM group, but we outgrew it. I don't know what the capacity is, but we outgrew it very, very, very quickly. So that was still like December. So by January, we already had like our Facebook group. And
Mm-hmm.
so on Facebook, it's a peer support group. So PTs, PTAs, OTs, anybody in allied health, who has long COVID, specifically that has long COVID, we're really careful about that. So it's a safe space.
Mm-hmm.
And then so from there, we started, I think the first thing we did was a 2-part blog for the Journal of Orthopedic and Sports PT about our lived experience, and
Mm-hmm.
then why pushing exercise is not the answer. And it has just snowballed from there. So we have a podcast I already mentioned.
Mm-hmm.
It's a combination of us telling our lived experiences and then having on experts within their areas. We have a blog that's up. We had started doing, I forget how often, monthly maybe, little Zoom calls, and whoever wanted to join to talk. And projects have just taken off. And then a couple months ago, we have our newly elected executive board as we're becoming more formalized as an organization. And
Right.
our executive board includes all of us who have long COVID and our allies. So our allies are the people who don't have it, but
Mm-hmm.
they are helping and they're doing the work. So maybe it's people who were already doing clinical work and or research in chronic fatigue,
Mm-hmm.
or were already respiratory PTs or anything like that. and they've demonstrated like a really big commitment to helping us with education and advocacy. So they're on executive board too.
Mm.
And what's really neat with the executive board is we have multiple people in all of the positions, knowing that those of us with long COVID don't always have the capacity to do everything. So this way you don't have to feel that your role falls just on you, that, you know, we have multiple people to help and split work up, which is really great. So now we have the executive board, we have our own Slack group to be able to organize everything.
Yeah.
And it's great. And even within that, you know, Darren was the lead, and a few of us, not me, but a few of us were authors on the briefing paper with World Physiotherapy, which is on safe rehabilitation for long COVID, which is so incredibly important. We have other publications that are coming out. We go on podcasts a lot. So in addition to the peer support, we do a lot of education and advocacy work.
Right. And for those who are listening or are interested in knowing more about Long COVID Physio, go to their website, longcovid.physio.
Yeah, nice and easy.
Yeah.
And I was like, this was good for your audience too. If anybody listening is a PT or other allied healthcare professional with long COVID, you're welcome to join our Facebook group. It's Long COVID Physio. You just have to answer a couple of questions confirming that you have long COVID, because it is great to have that peer support. And it's the twofold, that one, we're, you know, patients going through it, so you can talk to other people who understand all the really weird, crazy symptoms. And then as clinicians, we have that health literacy, where sometimes in some of the other groups it's difficult because there's people who don't have a health background and they're trying all these things and it's not safe and it's messy. But we, you know, we all kind of have that same level, and we all work in rehabilitation. To me, that's the crazy part. Like, we are the real rehabilitation experts in this condition that needs rehabilitation. So that's where the group is really helpful too. So that, you know, journal articles and things get posted also.
Right.
And like I said, it's a safe space.
Right. And some people who don't understand would tend to invalidate what you're experiencing. That's the hard. I think that's the hard part there.
That's been really frustrating. From so many different areas in healthcare and just the mainstream media, saying that it's not real. There's actually just, I won't say where, but an article that just came out in a pretty big, not a scientific, but a pretty big publication. And the tone was like sort of mocking long COVID, that this isn't real, which is really frustrating. This is not the first time that's happened. So there are some great journalists, like Ed Young is a great one, who has published some amazing pieces on long COVID, and that's been so helpful, which is really important, because as patients, even when we're clinicians, we can say everything we're going through, say, hey, literally, this is the space we typically work in for our jobs, but there will still be people saying, nope, you're crazy, it's in your head. So as we get more support from like outside people, whether they're journalists or clinicians or researchers, it's so important, because, and this I've learned a lot from the chronic illness community, because my Twitter, usually I was just following PTs and athletic trainers and people in sports science. And now there's a whole aspect of like chronic illness Twitter I didn't know existed, and learning all the gaslighting that goes on, and people just being told your CBC is normal, so you're fine. And they're saying, no, I'm not fine. Here are all these symptoms. I'm telling you, this is wrong, and just not being heard. Or being put through treatments, like I was saying before, graded exercise or cognitive behavioral therapy is another one, that's not getting to the underlying root of the problem. So it's so important for all of us. That's why we keep speaking up and using our voices, and thankfully have like allies who are helping too, to try to, you know, I don't know, overcome or try to help with all the invalidating that unfortunately goes on.
Right. I guess it's somewhat understandable, because everything's new, but I mean, since a lot of people are already saying that it's, you know, a lived experience, why negate it? Why invalidate it, and not just like study it and learn more about it, right? So
what I'm learning with that, and again, this is a lot coming from the chronic fatigue community, is as healthcare professionals, sometimes when we're faced with something that we don't know, or like, oh, that's not what I thought was going to happen, we're like, the patient's the problem. It's not us not knowing, it's the patient that's the problem. That's the way things get viewed, unfortunately. Or there's so many stories of patients going to multiple doctors looking for help, and everyone's like, I don't know. And they just dismiss them, because that's the easier thing to do than to like kind of admit you don't know what's going on. It doesn't mean you're bad at your job, you just, you know, don't know, and that we have to do more work and we have to do more research. And that happens, unfortunately, all the time. I think a really interesting example I just learned about recently was with multiple sclerosis. It was called hysterical paralysis.
Oh, really?
Before they had imaging to show the central nervous system lesions. They were just
Mm-hmm.
saying it's in your head. And now we know, like, you can clearly see MS on imaging.
Right.
But before that existed, they were dismissing patients. And so this long
Mm-hmm.
COVID, chronic fatigue, post-viral illnesses in general, it's no different, unfortunately. But now I think why we're getting more attention is there's so much of us all at the same time.
Mm-hmm.
Post-viral illness is not new. People have experienced similar things from mono and the flu and
Mm-hmm.
CMV. But now there's just such a huge volume of us all at the same time saying the same thing that people are finally taking more notice. Not that they were noticing before, but it's much more than what we've seen previously.
Mm-hmm. And it's even harder to dismiss because you're in the healthcare and you know what you're experiencing, and it's not in your head.
Right. Although I will say we have dealt with other people within our profession or other healthcare professions who try to psychologize it away.
All right.
And which, I mean, we do know obviously
Yeah.
having a positive disposition and things like that are beneficial,
Mm-hmm.
but that's not going to solve this. So we
Right.
have to, we keep explaining it's not psychogenic. There can be
Mm-hmm.
a psych component to it. People,
Mm-hmm.
obviously, if your life drastically changes and you can't do the things you used to do, it would not be uncommon to have anxiety or depression or anything else, but that's not the root cause.
Mm-hmm.
It's the virus is causing symptoms that are then leading to some psychological things for some people.
Right. So wow. I've learned a lot, and I have some realizations as well. I might want to research on myself as well and test out get some wearable heart rate monitors and see what's going on with me. But thank you for for the work that you do in long COVID physio,
Oh, thank you.
in increasing the awareness for people who might be experiencing some persistent symptoms from COVID. And thank you for being in the show in in this
Oh,
podcast
I
as
have to
well.
thank you. I appreciate it so much being here because the more we can get information out,
Mhm,
the more we can educate our colleagues and just make
mhm,
people aware. Because even if a PT isn't treating someone for long COVID,
mhm,
it's so important to be able to recognize it because you might be seeing a patient for something else and they just happen to say in passing, or say you give them their exercise program for the orthopedic condition and then they're crashed from it. It's
mhm,
just that you have like the little moment, you're like, oh, this sounds like something else I heard about before, that you at least can recognize it and then know to
mhm,
refer them. Because we as
mhm.
PTs, we might be the first person to pick up on this. The person might not realize they have long COVID, or they might have been dismissed by, whoever else they had seen previously.
Right.
So the more information we can get out, the better. So thank you so much for having this
Mhm.
episode.
And I like the what you shared about stop, rest, and pace. Because when I was spreading out the news about long COVID and rehabilitation from World PT Day, that there was banners and stuff, I now realize that there wasn't, that part that exercise exercising is or can be detrimental for them. So that's a new realization for me. So it's better for them to pace themselves, relax, and just manage that symptoms post exertional.
Yes.
Hmm.
Yeah, and us being
Amazing.
open to, as we've said, like it's not necessarily deconditioning. There's plenty
Hmm.
of stories in the news of professional athletes, Division I athletes, Olympians, things like that, who are really struggling with this. So
Hmm.
sometimes, unfortunately, it's easy to dismiss like an everyday normal person. But
Hmm.
like, are you really going to say that to the Olympian? No.
Wow.
Yeah. So there's
Right.
plenty of story, examples like that where like maybe exercise is not for everybody right
Hmm.
now.
Hmm. Right. Yeah. Gotcha. All right. So again, thank you for being in the show. Before I let you go, I usually close my interview with three last bites. My three last questions for you. Might not it's not about long COVID, but so my first question is um well, the questions are, since my podcast is about PT meal, so it's about food. So
Mhm.
so the first one is, if you're a dish, what type of dish would you be?
Ooh, that's really a good question. Ooh, I'm gonna go. Oh, I wouldn't have thought of this. I'm gonna go with a curry dish
Curry. Hmm.
because
Why curry?
there's that little kick to it.
Uh
There's that
huh.
little bit of spice,
Uh huh.
which, um, if anybody follows me on Twitter, I am a little outspoken, a lot
Hmm.
outspoken on some certain things. So I think curry, while it's nice and healthy and vegetables and things, there's like that little bit of kick in it too.
All right.
Good
Nice.
question.
So my second one is, what's your recipe for success?
Oh, oh, this is so different now
Yeah.
than if you had asked me this 2 years ago.
Okay.
So different. To pace yourself. I think as PTs, we're like super type A, and it's just trying to do everything all at once and take everything in and take all the courses, go to conference, go to all the lectures and everything.
Right.
And that's not that you will burn out or you get long COVID. So it's learning how to kind of pace yourself and
Mhm.
obviously have goals and know what you're going towards, but not feel like it has to be this 100% all in kind of thing that you're looking at like that long term, the long game. And like, all right, I'm here, but I need to get all the way down here, and doing everything all at once and, burning the candle at both ends is not going to work. So like learning how to pace things out because we have
Mhm.
time, you don't have to do everything all at once. Pacing.
Right. Yeah. Even if you don't have long COVID, and it's a good advice. Yeah. Because especially nowadays, there's a lot of things going on around us, and there's no sense of, as you said, burning the light too fast. Take your
Yeah.
time.
I am the cautionary tale because I lived very differently before long COVID.
Uh-huh. You're very
So
fast
so pace,
paced.
yes, yeah. So giving yourself some breaks and pacing is very important to be able to sustain whatever it is that you're doing.
Gotcha. Pace yourself. All right. My last question is, what are the three ingredients? It can be your motto, principle, value, or something that you live by. Three ingredients that make up Daria.
Oh, stubbornness.
Stubbornness.
I openly admit this,
Mhm.
and until long COVID, like it got me to where I am.
Mhm.
I am learning still how to kind of, not be as stubborn and be open to things. And I know that stubbornness can be viewed as a kind of negative thing,
Mhm.
but at the same time, it's like I kind of stand my ground on certain things. Like,
Mhm.
no, this is important. This is definitely what I want to do.
Mhm.
This is going to sound really silly, but rainbows.
Rainbows. Yeah.
This is one of my friends joked that rainbows are my aesthetic because I'm LGBTQ rights are like super important to me. So
Mhm.
rainbows. But at the same time, I found there's a quick little story. I have a really negative neighbor who doesn't like anybody. He's very hateful. So I took my what a really passionate thing for me, LGBTQ rights, and I cover my lawn in rainbows with flowers and some like nice decorations and stuff. So as a way for me to sort of have a message without just like throwing it, like without
Mhm.
having to preach to you.
Mhm.
So that's the thing I've learned to do is like I have rainbows and they make me happy. But that
Uh,
is a really big thing that people who know me, like there's rainbows like all
all
over
around.
my room right now. Yeah. So I have to think the stubbornness and the rainbows. And the biggest thing, this is kind of interesting with long COVID now, but honestly, movement, where I have
Movement.
been a dancer since I was 3 years old. And even though
Mhm.
I'm limited on dancing right now, I'm still dancing around my house. I'm always
Mhm.
like, always doing stuff and always choreographing in my head and coming up with things. And that allows me to process stuff, that allows me to think, that allows me to like, to come up with better ideas usually.
Mhm.
So even now, while like my movement is sort of limited and I have to restrict it, that is still like so incredibly important to me.
Mhm.
There you go. There's three
Yeah.
things.
Three things: stubbornness, rainbows, and movement. Three things
Yep.
that make up Daria. All right. Again, thank you very much, Daria, for being in the show and sharing your experiences with us, being candid on how you got your COVID, and discovering what long COVID symptoms is, to the long COVID physio, and sharing and building up the awareness of the symptoms, and helping others about managing it. So as a takeaway, or our to go boxes for them to bring them at home. So what is one thing that you want to take away? What you want the audience to take away from this podcast?
Yes, listen to your patients.
Mhm.
Even if you're like, I don't know what's going on, maybe
Mhm.
it's long COVID, maybe it's something totally unrelated, but just to listen to them, as I said, like, and validate them, that regardless of what they're telling you,
Mhm.
how crazy or may not it might sound, to validate that, yes, you understand this is what they're experiencing. You're not telling them that it's in their heads. Um, that is the best thing we can do, even though right now we don't have all the answers, but to listen to them and make sure that they know that you are a person that is a safe person for them to talk to.
Mhm. All right. Perfect. Listen to your patients. Try to get into what they're really telling you. All
Yes.
right. Again, thank you, Daria, for being in the show.
Oh, thank you for having me.